Everyone. I'm Audrey Russo, and I am thrilled to be here. I am so excited. I'm sorry I hesitated for a moment just to make sure I was on. So good afternoon. I run the Pittsburgh Technology Council. I have one of the coolest jobs in the region, but you're going to hear from someone and a couple of other people who have even cooler jobs. So I won't brag on that. So let's just talk about, I am joined today by someone on my team, Marie Poloni. She is our STEM engagement coordinator of our nonprofit. Listen to me. I've been home too long, but 40 by 80. And that's our nonprofit arm of the Tech Council. And she is our STEM coordinator, which means that she has a background in math and science, and she is our in-house nerd. And we love her for that. So we are thrilled to have you join us today on our virtual STEM Summit. And Dr. Patek with the Allegheny Health Network showing us the role of technology in her work. You're going to be blown away. And she's a surgeon. So we have over, let's see, 1,000 people, 1,100 people that have registered, including students, parents, educators that come from all over 130 school districts. So we're very excited about that. So a little bit about the Tech Council, and then we're just going to rock right into this show. We are an organization that's consisting of over 1,000 local technology companies and manufacturing firms and firms that are in life sciences. We come together to help make our region amazing. That it's a great place for people to live, a great place for people to work, a great place for all of you to have jobs and the future. And that's really the most important thing here. It's about talent, it's about people. So listen to the people who are going to be joining us today, and you're going to be really excited about the opportunities that you can have a life here in Southwestern Pennsylvania. So the show is being recorded, and thanks to PCTV, it's being simultaneously broadcast, so it's available on demand, and you can download the app on Apple TV, Roku, or Fire. And if you live in the city of Pittsburgh, you can just watch us live on Channel 21 on Comcast or 47 on Verizon. So I'm going to pass the baton. I mentioned a little bit about Marie. She is a science and math teacher in a previous incarnation, and now she is hanging out with us. And thanks to the charitable work of PNC, we are bringing this to all of you, which includes industry leaders to bring into the classrooms, particularly in middle school, what's happening so that you can see what the possibilities are. So I'm going to pass the baton. Thank you for being here. Thank you to all of our sponsors. And now I'm introducing Marie.
Thank you so much, Audrey. And thank you, Dr. Patek, for joining us today. I'm going to talk to you all a little bit about how you can get involved today. We really want maximum engagement from all of our participants. So today and each day of the STEM Summit, we want to make sure that you're able to ask questions and that you're able to type those in at the bottom of your screen. So if you look down there where it says Q&A, that's where you send questions to me. And then I can ask them of Dr. Patek as she is showing her presentation today. You can also raise your hand, and that alerts me that you do have a question. If you're watching this through PCTV, if you're watching this live, there's a spot for you to type in questions, but we can't see them. I just want to make sure you know that we are not ignoring you. Throughout the day today, the speaker is also going to have questions for all of you. We have some student panelists who are joining us, and these students are pretty amazing. They were recommended to us by their teachers, by their parents, and they're going to jump on today and ask these polling questions. When the polling questions appear on your screen, you're just going to log in your answer and then see how your answers compare to everyone else's. So without further ado, and before I introduce Dr. Patek, some of the images today are going to be, well, we're talking about internal medicine. So you just have to make sure that you're ready. Viewer discretion is advised. We are going to be looking inside of our bodies. So we just wanted to make sure that you were prepared for that. So now I will hand it over to Dr. Patek. We are so happy to have you here today. It is wonderful to meet you.
Hi, everybody. My name is Bonnie Patek, and I am the Chief GI Fellow at Allegheny Hospital, General Hospital. So what that basically means is that I am finishing up my training officially on June 18th, and at which point I will sit for my boards for gastroenterology. I started the path in medicine about a decade ago, so it's a really long trip to get from sitting in a classroom all the way to having my big girl job. So in order to become a gastroenterologist, which just a minor correction, I technically don't do surgeries. So you don't want to come to me to get your gallbladder out or anything like that. As a gastroenterologist, I do upper endoscopies, I do colonoscopies for screening purposes, and many other reasons why we do colonoscopies. Really interesting things in the field of gastroenterology that utilizes technology a lot. The artificial technology is starting to become a huge thing in our field. Sometimes we're starting to utilize that to look for things like polyps, which are growths that are within the colon that, if left untreated, can potentially turn into a cancer. So there's a lot of technology now being utilized into helping us look into the colon and not only use our own eyes to find these polyp growths, but also use the computer technology to do it as well. And there's many other things that we've been doing. So with, if it's okay, I'll move forward to showing our first colonoscopy. So
I'm actually just going to stop you right there.
Okay.
Just want to know, in listening to you talk and the important work that you do, I want to know how many participants on the call really have an interest in looking at a career in medicine. So I'm going to throw a question up here on the screen. And this one is, Ria's going to be asking this. Go ahead, Ria.
Hi, so do any of you have an interest in pursuing a career in the medical profession? Yes or no?
Great job. Thank you, Ria. Go ahead and log that in there. There's so many vast careers, and something that we really want to get across today, and I know this is important to Dr. Patek too, is there's so many careers, so much training involved, and different educational pathways to get there, all the way from 6-month, 2-year degrees to a decade, like Dr. Patek was explaining. All right, I'm going to go ahead and share these results. This is good for all of us. It looks like 60% are interested in the medical profession, so you can really have an impact with that today, Dr. Patek.
So yeah, the medical field, like we mentioned, there's so many different aspects that you can go into. There's surgical aspects, there's internal medicine, there's family medicine, OB-GYN, which is dealing with pregnancies and complications with that. So there's lots of different options to that people would have to go into a medical field. But like we talked about, it is a long trail to get there. You do of course, your high school, and then in order to move forward, you do your 4 years in undergrad, which you can actually major in really anything. There are people who go to medical school who were majors, had an English degree in college. So you don't have to do biology if you wanted to do medicine. You just have to take prerequisites, which include chemistry, biology, organic chemistry, and a focus of science, but you could totally study Russian literature if you wanted to. You don't have to be purely science. And then you would take an exam that is kind of an entry-level exam to get into medical school called the MCAT. And then once you're into medical school, that is a 4-year schooling. Once you complete that, there's a lot of exams you take throughout the whole course of that. Then you start, for me, my course was internal medicine. So I did 3 years as an internal med resident. I graduated, I completed my board. So I'm a board certified internal medicine physician. And then I applied for my gastroenterology fellowship, which is an additional 3 years of training. And then again, I will take another set of boards and have my real job at the end of that. So
I mean, that is so impressive. That is such a long road. That is so impressive. Did you always want to be a doctor?
So that's actually a great question. And the answer is no, I did not. When I was in high school, I really liked science. I kind of was terrible at physics. I wish I was better, because maybe if I was better at that, I would have gone an engineering route, like my brother. He's an aeronautic space engineer, very smart. So we're two different sciences. But I was actually more interested in like benchtop research and actually cancer research for a long time. And then through college, my experience of doing kind of benchtop science made me realize that maybe that wasn't exactly for me. And I really enjoyed the interaction with people. So then I kind of looked towards what I could do with my already budding science interest, and that kind of led me to medicine. And at this point, I'm like I said, a decade in, so I'm not turning around now.
No, and the work that you do is so important. Some of our participants here definitely have an interest in tech. And so, Braden, if you wouldn't mind reading this question for us, I'm just going to launch it just before we start to look at some of the tech that Dr. Patek uses. What different tech is used in internal medicine? So, Braden, if you could read this one for everybody. Oh, Braden, I think you're muted right now. That's okay. Go ahead.
How do I get back to the question? I'm sorry.
Oh, that's okay. I will relaunch it. All right, there you go.
How do doctors like Dr. Patek use tech in the world of internal medicine? Robotic surgery, RAS, small capsules containing a camera that travel through the body, miniaturized instruments that have a high definition 3-dimensional camera sent through small incisions, or all of the above.
Thank you, Braden. And I'm actually going to leave this one up for a little while. Go ahead and place your answer there. But Dr. Patek is just going to use this to talk about what we're about to see today before she shows you some really cool videos.
Yeah, so in terms of looking at this question and from an internal medicine world, I personally will not be doing the robotic assisted surgeries, but that is something that's utilized more in the surgical world. We always try to do things with robotic surgeries now, or laparoscopic, meaning not cutting open the whole stomach area or the whole abdomen and going in, but using these small instruments to kind of go in and take things out like gallbladders or even colons to some degree. For the personal GI world that I live in, this camera is definitely something that we do. That's called a video camera endoscopy. And it is a camera that is kind of like taking a pretty large pill that someone can actually swallow. And it takes thousands of pictures of the entire GI tract, all the way from our mouth to the anus. And throughout that, what we're doing is we're looking at the small bowel predominantly with that. So again, it takes thousands of images. It lasts from anywhere from 8 to 12 hours, and it gets us a good look at the area of the intestine that we may not be able to reach with our scopes. In terms of miniature instruments that we can use, so again, we're not doing through the skin cutting. However, with our scopes, we're going through either up through the mouth, and we're looking at the esophagus or our food pipe. We look at our stomach, and we look at our small bowel, which is our duodenum or jejunum, or our medical terms for those areas. And we can also use a specialized scope to get into the bile ducts, which is our drainage system of the liver. Kind of get up into the bile ducts and look around in those areas. And we can actually use, we've had technology now where we can take our scope down and we can actually place another smaller scope camera through our instrument channel to even get up into the bile ducts, which is even smaller. So we're kind of using like a scope within a scope to try and get to different areas. So there's a lot of technology. And the other way that we use is, of course, we'll do colonoscopies like we talked about earlier, which is our predominant screening method for colon cancers, where we're taking a camera. It's essentially kind of about the size of my finger, and it's going up the bottom. So it's going through the anus, and we're going all the way through the colon, and we can get into the end of the small bowel there, again, using the different instruments and different, like we talked about, the artificial intelligence that is a new emerging field in our area to try and look at different issues with polyps or colon cancers or things like that.
Thank you, Dr. Patek. All right, so let's take a look at what this looks like.
All right. Bear with me for a moment. Okay, so can everybody see my screen okay? Hopefully, thumbs up. Okay, thumbs up, good. Okay, so with this here, all right, let's make sure it plays. All right, looks like it's having some technical difficulties at the moment, so let me see if I can find another way to play it.
That is fine. We appreciate you troubleshooting that.
No worries. I apologize. It didn't seem to want to work. All right, let's try it again here. Okay, is this better? We can see?
We can see.
Perfect. Okay. So this essentially is the beginning of our colonoscopy. So we use, again, our camera. And what we're doing now is we are inside the colon. And in order to get a great look at the colon, I don't know if anyone on the line has either had to experience a colonoscopy or had loved ones that have had a colonoscopy. The worst part of a colonoscopy is the day before. And that's when we ask you to do a prep. And then the reason we need you to do a prep is because your colon's job is to hold stool, and it absorbs water and some degree of nutrients, but it's full of stool. And obviously, if we were to place our camera in a colon that's full of stool, we're not going to see anything that we want to see. We're just going to see a bunch of stool. And what we want to see is this beautiful colon here, which is perfect. We can see the nice lining of the colon, see that it's healthy looking mucosa, which again is the lining of the colon. So that worst part of the colonoscopy truly is the day before, where we ask people not to eat anything. They can have clear liquids throughout the day, like jellos and broths, but that's really to help purge the colon. And then we ask people to drink this kind of large degree of laxative, again, to purge the colon of all the stool. And this is so important in this setting because what we're looking at with this colonoscopy is it's for screening purposes at this point. So what that means is this person was completely fine. They had no GI complaints. They had no GI problems. They were just coming in because they wanted to make sure that they did not have any underlying polyps or any underlying diseases that may eventually lead to a cancer. So this is purely a preventative strategy on our standpoint to try and prevent colon cancer. Depending on which guidelines you look at, a lot of times we will hear, age 50 is a big target. So everyone at age 50, it's recommended that they have some degree of screening for colon cancer. And our guidelines, the most effective way is a good colonoscopy. For African-American population, it's recommended at a younger age at 45 because of a higher risk of developing these polyp lesions that we can take out. So here in the video, what you're watching is, again, is the kind of camera is going in and out. We're kind of making our way through different turns of the colon to kind of get to what we call the end. So there's different parts of the colon. When we consider at the end is something called the cecum. And what that means is it's basically where the area of the small bowel kind of dumps its contents into the colon. Once we know that we've made it to that area, that's when we actually start not per se the procedure, but that's when we start using the camera to look for polyps. As you notice, when we were kind of going our way into the colon, we weren't really, we're not really looking at everything per se. We're just trying to get to the end. And then our screening and looking for polyps is on the way out, because that's when we kind of really take our time. So we have actually reached the end of the colon here. This image that we're going to get ready to look at is the end of the colon. And we know that because of certain landmarks that we're looking at. And if you notice, I don't know if you can see my arrow on my screen or not, but this little area right here is a little bit different looking than the rest of the colon. I know that might be hard to tell, but we'll get back to that because that actually is a small polyp that we will be taking out. What we're doing now is we're actually getting into the end of the small bowel. So you notice that this tissue lining looks a little bit different. It almost looked like a little bit of a shag carpet. And that's how we know that we're in that small bowel. And the small bowel has that kind of shag carpet appearance because it is absorbing all of our nutrients. Now you can see that the scope has kind of turned on itself and we're looking back down into the colon. And what that's doing is we're getting a good look at the behind the folds of the colon to make sure there aren't any hidden polyps there, which sometimes they can hide. So again, we kind of talked about here how there's this small little area here that is a little bit different, a little bit raised, and that is a polyp. So our goal at this point is going to be to take the polyp out. Obviously, you can see there's a little bit of blood, so hopefully nobody's squeezing. But that is actually not uncommon. It's almost essentially like getting scraped, like if you were to run and scrape your knee or something, that's what that is. So the instrument that's out now is called a snare, and we're literally grabbing the tissue of the polyp and we're going to cut it. So again, we're creating this kind of scrape of the lining of the colon to remove that polyp out. And essentially what we do is we take that, it goes to pathology. So we'll have our pathology colleagues take a look at it under the microscope and tell us specifically what kind of polyp it is. And based on its size, what it looks like under the microscope would be when we'd ask somebody to come back and have another colonoscopy again. So this is essentially what we do for, again, screening purposes, but there's many other reasons why we might be getting a colonoscopy. If people are having bleeding from internally from their bowels, they may need a colonoscopy. Some people have issues with what's called inflammatory bowel disease, like Crohn's disease or ulcerative colitis, in which case we do colonoscopies to kind of assess how the disease looks. And in terms of different kind of technologies that we utilize, this essentially, the colonoscopy or the colonoscope has kind of been around for a little while. They're upgrade with the exception of we use different types of imaging. So for instance, what we're looking at right now is called white light imaging. So it's just a normal camera, but the different types of scopes that are out there, the ones that we're looking at here right now is an Olympus scope. Some of you may have heard that from cameras before. There's also a Fuji brand that makes the scope, and there's a type of imaging called a narrow band imaging. So again, different types of camera technologies that we use. And what that narrow band imaging is doing is really kind of changing the focus of the camera, so we can really tell, is there differences in the mucosa? So is the area of the colon that we're looking at look normal compared to the area right next to it? Or are there some weird looking blood vessels that are showing up that might be a sign to us endoscopically that this might be a precancerous polyp that really needs to come out? So without that extra technology, sometimes it's really hard because some of these polyps are, or there might be a little bit of stool, so we won't be able to see them. So really having the ability with enhanced technological aspects is really helpful. And you can see now we're kind of like going back into the colon. The reason we kind of go back in multiple times is just to get a really good look, especially of that right side of the colon, because that's where a lot of flat lesions can kind of hide. And what we're doing here is we're kind of spraying off that scraped blood area. And we'll actually see that there looks like there may be a little bit of residual polyp that's left. So what we'll do is we'll actually go back in and take out a larger piece to make sure we get everything. And that's kind of what we're going to be looking at here.
I'm going to interrupt you for 1 minute because we have some great questions here going on in the Q&A. So Madison is asking, is the camera moving with the bloodstream, or are you controlling where it goes?
So that's a great question. So we control the camera, and what that is when we place the colonoscopy or the colonoscope into the body, we have two control dials essentially. So there's one, when you look at the tip of the scope, it's either moving up or down, or we can use a smaller dial that moves the camera left to right. And then we actually use, so that's all controlled in our left hand. And then the right hand is actually utilizing what we call torque. So you twist it one way, you twist it another way, so you can actually move the scope depending on which way you're moving the thumbs and everything. So we'll follow and try and keep what we call the lumen, or the open area of the colon, in view as we're moving back. So you can tell, see, we're kind of twisting everything. It's kind of like a fun video game at times, which is why I kind of really got into it. I was a big video player when I was like a kid, and I thought this was kind of cool. I can go to work and essentially play a video game and help people every day. So, and it's not
that you do for sure. Jacqueline has a great question, and Jacqueline has had great questions every day. So I'm so happy to see you back again today, Jacqueline. But Jacqueline wants to know, do you feel the surgical world is much better due to the new development of all of this different technology, as far as in the decade you've been in schooling, watching those cameras evolve?
Yeah, so specifically from a GI standpoint, that's a great thing to bring up, is yes, the optical definition of these cameras has definitely improved. If you go to areas that may not have the most advanced stuff yet, because advanced things are really expensive sometimes, and smaller areas sometimes may not have the ability to afford those yet. But when you look at, even through this decade, when I look back at training videos from a camera that may have been out or really popular and advanced 5 or 6 years ago, the definition is much less. So this definition that we're looking at here, these are the most advanced Olympus scopes that we have currently. It's wonderful. And I don't know, maybe no one else has seen inside of a colon before, but this is actually very good. So that's why we were able to see that really small polyp that was there. And looking back, that polyp, you know, you might think that's really small, it's not that big of a deal. But if you said everything looked great and this patient back in 10 years, God forbid something were to happen and that polyp develop further and turn into a colon cancer. So with this improved definition of the camera, we're definitely able to visualize things better.
That is fantastic. And I know you have another video to show us, and it's something that we're all really interested in, but sort of the capsule for endoscopies that you're able to take orally. Would you like to transition into talking about that?
Sure. So we'll stop sharing that. So I'm just verbalizing what I'm doing since
I'm glad. I appreciate it so much. I do want to say too, we had Ryan join us, which I'm so glad. So Ryan, I think you joined us as a student panelist as well. And I just want to highlight you. We're going to have you do a job here in a moment, just while Dr. Patek was pulling that up.
Yeah, so these are, let me pause it here. So can everybody see the screen with the camera or with the small bowel, hopefully?
Yes, we can see it. And maybe just before we look at this, can you talk to them a little bit about what this capsule even is, what it looks like? I know it's new to a lot of us.
Yeah, so what a video capsule endoscopy is again, it's a very small camera that honestly, it's probably about this big. So it's a pretty big pill that you would swallow. You swallow it whole, and it essentially is taking thousands of pictures of your small intestine. So when we do our upper endoscopies, we get a really good look at, again, the food pipe or the esophagus, the stomach, and the very beginning of the small bowel. And we do have longer scopes that we can get even further in. But your small intestine on average is about 600 feet. So that's a lot, or 600 inches, I'm sorry, centimeters. So that's a very long distance, not feet. That's a very long distance to look at though. So we don't have scopes necessarily to get all the way through everything. So this capsule allows us to really localize issues that we're looking at. So we do this in people who have underlying things like Crohn's disease, or if they're anemic for other reasons, which means they have low blood counts, they're losing iron in their stools for whatever reason, if there's a slow bleed somewhere. So that's why we're looking for this. Some people who have history of different type of genetic disorders may develop polyps or make polyps in the small bowel. So that's another reason why we do this procedure. And essentially, you know, you swallow the capsule, it takes thousands of pictures. We then look at all of those pictures and then kind of decide, do we need to do a procedure? Do we need to do additional imaging? Do we need to do surgery? So those are different things that we can look at with this.
And Ray wants to know in our Q&A what that capsule is made out of. Do you know?
That's a really good question, actually. So it is made, I know there's plastic in it, which is a terrible answer, but we actually have two capsules that we utilize, and there's different companies that make capsules. We use an Olympus one here, and the capsule itself is a plastic large capsule with a clear cap on the end of it for the camera. Is another capsule called a patency capsule, which we may utilize in somebody that we think maybe the capsule would get stuck. So this patency is actually something that would dissolve in a few days. So that way, before we place this real plastic capsule that is not going to dissolve because it will pass in, or its goal is to pass in the stool. We never want the capsule back in this case. Some capsules you do retrieve and bring them back. The one we use, we don't want it back. You can keep it or flush it. But in terms of the patency one, that one would actually dissolve. So if it were to get stuck because someone has a narrowing of their intestine somewhere, it would eventually dissolve and not cause any problems.
Thank you. Okay, thank you for explaining that. I think we're ready to see it in action.
Okay, great. So this is a very short clip, and this is something that for training purposes, when going through my career, we look at a lot of different training capsules. So this one will show a little bit of bleeding. So another reason why we would do a capsule. So we'll just play it. Hopefully everyone can see it. You can kind of see on the right side, you see this kind of stream of red that comes out, and it's a very short clip, so we can play it maybe again in case somebody missed it. But again, kind of over here in your area, you see the stream of red that's coming out. So that's a little bit of blood that's coming out somewhere within the small bowel that we could see on this capsule. So then basically what, we have another video here. What we can then do is when we see something that's bleeding like that, we can actually go in, depending on where we think that lesion is based on where it was on the capsule endoscopy, and treat it. We generally can burn areas that are bleeding. We can clip areas that are bleeding. We can inject medications into areas that are bleeding to see if we can stop them. So in this case, what we're looking at is something called an APC device, which actually uses argon plasma coagulation. So it's a different type of gas that we use that actually coagulates the area on the mucosa. So we see that there's bleeding that's going on there. We kind of squirt it off with our water jet to find the exact little pinpoint area. And then we can use, again, the different types of modalities. In this case, it's using that argon plasma gas to kind of burn that area and stop the bleeding. So you'll see in the video, there's a little bit of burning. You see this white kind of area around the, where the initial bleed was. And that basically shows that things have now stopped bleeding.
That is absolutely fascinating. And again, you're controlling all of these. So the capsule is taken orally, and then you control the tools from there.
Yeah, so the capsule itself is purely what we would call diagnostic, which means it just shows us what we're looking for. When it comes to actual therapies, those are things that we control utilizing the scope. So when we have our scope, either our upper endoscopy or colonoscope, we have a working channel where we place different instruments into that. So that would either be like that blue tube essentially that you saw that was shooting out the gas. We put down biopsy forceps, so they look like little pinchers that kind of literally pinch off mucosa. So we can utilize that to look under a microscope. There's also different types of scopes that we have. For instance, there's something called an endoscopic ultrasound, which is another technology that we use, and that is great for different reasons. So for instance, if we're concerned that there's a mass or a cancer like in the pancreas, we can actually go down with our scope into the stomach and beginning part of the small bowel, utilize the ultrasound portion of a scope and actually see the pancreas. And we can even take a needle and go directly from the stomach or small bowel into the pancreas, take a sample of that mass, and then we can use that to tell, is it cancer, is it not cancer? And we can actually also do certain other technologies to treat pain if it's related to a pancreatic cancer. And we can use the ultrasound for many different things. So not just cancers, but we can use it for other things as well. But that's a different scope that we use that has this ultrasound technology kind of built into it.
We had a participant ask, are these the newest technologies that are available for endoscopies and colonoscopies? Do you feel that we in Pittsburgh here have the most up-to-date technology?
Yeah, so that's a great question. I think we do. There's a lot of advanced work that's going on. So there's always what we call your bread and butter. So those are like the upper endoscopies and the colonoscopies for screening purposes, or if somebody has reflux disease, those haven't changed too much in terms of, when we get the new scopes with the good definition, that's what we utilize. But here, at least in Pittsburgh and with Allegheny, we're utilizing a lot of that endoscopic ultrasound to see that we can kind of advance our almost, I don't like to use the word surgical because again, we're not surgeons, but we're doing a lot more stuff now endoscopically. So we don't need to do things to open up the belly. For instance, if somebody has a hiatal hernia, which is kind of an area between the esophagus and the stomach that maybe, your stomach is supposed to be below the diaphragm. If it's starting to come up a little bit and you're getting really bad reflux, there used to be, or there still is, a surgical procedure called a fundoplication that kind of wraps the stomach around the esophagus. There's actually now we can do that endoscopically. So we don't even have to, necessarily do a surgical procedure to do that to stop reflux. We can do something like that endoscopically. With the ultrasound technology, we can help with issues that result from bad pancreatitis cases. If there's large cysts that form, if there's necrotic debris that form. Nowadays, most people don't go to surgery with really bad pancreatitis. We can actually drain those areas utilizing that ultrasound. So we actually create a tunnel between the stomach or the small bowel with this cyst or this necrotic area and just drain all that debris into your intestine, and you literally poop it out. And that way you don't have this big surgery, but you're treating people that way. So I would say we definitely have a lot of cutting edge things here that we're doing and trying to utilize with as much technology as possible.
Yeah, we've always been so proud of AHN and the work that you do and appreciate the endless amount of time that you put into it. I know we have some more questions from our student panelists. So let's see, Braden, if you're prepared, you want to jump on and ask?
So my question was, what advice do you have for those who would like to pursue a career in the medical field?
So great. For anybody who's interested in the medical field, I would say that really good advice would be to figure out not necessarily what you think you like, because things can easily change. But try and shadow people. So if you have a neighbor, if you have a friend, your mom's friend, or somebody who's a nurse or an EMT or a physician, you can get experience by being able to shadow them and see what they really do day to day. That's the best thing, because there's tons of TV shows out there about medicine, and almost none of them are accurate. So it's better to actually get an idea of what your day-to-day life would be like if you can really see it. But in terms of, starting off young, like I said, I was late to the medical field in terms of when I was in high school, I was worried about soccer and I played lacrosse and all these other sports. I was not worried about medicine. I was not worried about what I was going to do with my future. So it's not something that is never too late. There are people that go back to medical school later in life. But I would say that the best advice would be to really immerse yourself in somebody that can tell you what your life is going to be like day to day, and figure out what priorities are best for you. There's a lot of fields in medicine that if, having a family is a very important thing for you in your life, then you could still do medicine. It doesn't be a doctor, you can do nursing, you can do tech, you can do PA. There's so many different things that you can do in that field. So really determine what you want out of your life and what things bring you pleasure, because the last thing you want to do is jump into a decade-long journey and it not be what you really want to do. So if you can get experience before going in, I think that's the best advice I could give someone.
That is beautifully said, Dr. Patek. Thank you for that. Rhea, did you have a question that you wanted to ask? Thank you, Braden.
Yeah, so I actually had a few questions. So obviously every job has their amazing yet difficult parts to it. So what would you say that your favorite part of your job is, and also your most difficult part?
So I'll start with my favorite part of my job. I generally like my job because I do like people. I like talking with people. I like the fact that I can try and help somebody take control over their life again. I'm not one of those physicians who's a big pill pusher, or, I generally think that a lot of things that we can do is kind of take control of your own life and figure out what has kind of gone awry and how you can make that better. So I like sitting, I like talking with people, I like learning from other people's experiences. The more you let somebody talk about their life, I think the more you can learn about them. So I generally really just like sitting and talking with people. So I think that's my favorite part of my job. I generally like my procedures, which is why I got into GI. I liked the aspect of some type of surgery, so I could use my hands and really fix something right away. But at the same time, with internal medicine, sit back and think about why we're doing the things that we're doing, and really get to connect with people on a personal level in the office, not just during the procedure itself. I would say, and then, so that was your first one. And your second question was about hardest part of my job. I would say that the hardest part of my job would be the long hours. So there are long hours, especially during the training part of your career. So medical school, there's so much information to try and learn. That takes a lot of studying, a lot of dedication. When you get into the other training, so once you do your internal med, at least for me, when I did my internal medicine and GI, the hours are long. So I miss my family sometimes. I miss hanging out with my friends. It's a sacrifice I chose to make, and I'm not unhappy with my decision. I like my job. I like what I do. But I would say that was the hardest part of my journey. Currently, the hardest part of my job, I guess, would be obviously with all of the new changes that are happening and everything in the world, kind of learning where to go from here. And keep everybody safe is probably the hardest part right now.
That is something that we are all hoping for, and we do appreciate your work in that, because that is a struggle as everything changes every day. In looking towards the summer, and I know this summer is a little bit different, sort of highlighting what you were just speaking about, but do you know of any programs at AHN that they offer to high schoolers who are looking at careers? Have you seen high school students come through?
So we in the GI lab here actually did have kind of a thing for high school students. Now, given that was last summer, I don't know what the status of it is this summer, but I'd be more than happy to try and figure out the people who ran it last year, what their thoughts are moving forward, whether that's something that just needs to be abbreviated or maybe not happen in June, but maybe happen later in July or August. But we did have some high schoolers specifically come through the GI department. And they went to different areas as well, because in the GI world, we work with other areas of medicine. So we work a lot with interventional radiologists, we work with surgeons, we work with a lot of different people. So it kind of gave everybody a different flavor, if you will, of other areas in medicine. So maybe they weren't 100% sold on GI, which is totally fine, but they were able to see other things that might be of interest to them. So I don't know offhand, but I do know we've had them before. So I'm more than happy to find out that, and I can pass that information on to you.
That would be fantastic, because just like you said, it's never too late to do a career in medicine. It's never too early to sort of try to focus in on what would be your passion or what you would have the most interested in. We are getting such good feedback in the chat. People are having to go, but they have loved this and thought it was so interesting. You definitely have given us an inside look at things that we have never seen before. And really just the importance of internal medicine. If you can't treat that internally, how you can take care of your whole self. Let me make sure. Did you pursue, Shira has a good question. Do you pursue the medical field throughout your family, or was it mostly your love of science? In other words, were other members of your family in the medical field?
Oh, that's a really good question. So no, growing up, my dad was in construction and my mom stayed home with me and my brother growing up. So I had the only experience I had with medicine was going to the doctor myself, and I hated it. So I don't know why I didn't.
That's fantastic.
Yeah, I did not like it. So no, my love for science was probably what did it. And then I found what science I liked the best. Like I said, if I was better at physics, maybe I would have gone a different way. But you know, the things with biology and the things of general like anatomy and that sort of stuff really was interesting to me. And I like the people connection. So that's the way I went in medicine. So I didn't, you know, me and my brother are the first ones in my family to go to college and that sort of thing. So didn't really have too many people to role model after, which is okay. But it was just, you know, it's a good question, because a lot of people you'll see sometimes in medicine had that, they saw their mom was a doctor, their dad was a doctor, their uncle, whatever. So I didn't have that, but I was able to get exposed to physicians and medicine in a different way.
That is fantastic. And that's important. That's a message that I want all of us to see, that especially with the changing careers, and especially here in Pittsburgh, we might not have a parent or a guardian or an aunt or an uncle who's doing a career that we have interest in, and that there are pathways to pursue it. We thank you so much, Dr. Patek, for having you here today. I'm going to throw it back to Audrey to sort of wrap this up, but I have found this so interesting. Again, I appreciate the internal look that you gave today that was unique to any experience we have had yet on the Virtual STEM Summit. Braden and Rhea, you guys were fantastic. Thank you for your help today. And Audrey, I'm tossing it back to you.
Thank you. That was amazing. Thank you so much for taking the time with us. Really mean it. So I just want to thank everyone for being with us today. I hope you enjoyed it. I want to thank all of our sponsors. You saw us referencing them at the beginning, and we are thrilled with their help. We've got gold sponsors, BNY Mellon, Giant Eagle. All of them are hiring. All of them could be your future. Lanxess and SDLC Partners. We have bronze sponsors of CGI and Industrial Scientific, and supporting sponsors of Gifta and Highmark. They're all hiring people across science, technology, engineering, and math. Although we did hear from physicians today, the world is your oyster. So join us tomorrow, same time, same link. We are having fun, and I hope you all are too. And if you have any questions or ideas, just shoot a note to Marie, and hopefully we'll put her email in the chat, or you know how to get a hold of all of us. So thank you all.